Ladies and gentlemen, I'm Clement Tham from the Chinese University of Hong Kong, and it is my great pleasure to present to you a logical approach in angle closure management that is based on angle closure type and mechanism. These are my financial disclosures, and also the government funding that has supported our PACG research. Now, tomorrow, I have another presentation on the surgical treatment of angle closure, in which I'll present to you 4 most frequently asked questions in the surgical management of angle closure. Now, the general principles in the management of primary angle closure glaucoma, the very first step is you try to open up all appositionally closed portions of the angle as far as you can. If the intraocular pressure is still uncontrolled, then you start topical medications. If IOP is still not controlled by maximally tolerated medications, then you may consider further surgery. There are different means to achieve the opening up of appositionally closed portions of the angle, and this includes laser peripheral iridotomy, argon laser peripheral iridoplasty, and also lens extraction. Now, there are several known mechanisms that leads to angle closure in primary angle closure disease, and these include pupillary block, plateau iris syndrome, lens-related mechanism, which may include the lens position, the lens thickness, and also perhaps acute lens swelling in some cases, and also possibly choroidal pressures increase. Now, this diagram here tries to illustrate the contributions of different mechanisms towards angle closure in different eyes. You can see 4 different eyes here, and the height of each of these columns represent the predisposition to angle closure in that particular eye. So the higher the column, the greater is the risk of angle closure. And you can see that in different eyes, the proportion of contributions from each of these 4 mechanisms differ. Say, for example, in eye number 3 here, the plateau iris configuration is the main contributing mechanism to angle closure, whereas in eye number 4, the lens thickness is the main contributing mechanism. Now, this second diagram here looks very similar, but this time this is the same eye, but at different age. You can see that with increasing age, the lens thickness becomes increasingly important in contributing to angle closure. And also, as a result of that, the contribution from pupillary block may also increase. And so with increasing age, the predisposition to angle closure generally increases as well. Now, the objective of surgical intervention in primary angle closure glaucoma is to eliminate as much of those risk factors as possible by selecting a procedure or a combination of procedures with the least amount of risk. Now, the next 2 slides, I'll try to summarize my management algorithm for primary angle closure disease. And the 2 slides represents 2 extreme ends of the clinical spectrum. Now, in this first slide here, we're looking at an eye with a hypothetical 360 degrees of complete appositional angle closure with ocular hypertension with or without glaucomatous optic neuropathy. With appositional angle closure, what that means is that if you have a laser or a surgical intervention that can deepen the anterior chamber, widen the drainage angle, and reopen the drainage angle, then likely the trabecular meshwork is re-exposed to aqueous outflow drainage. So under these circumstances, you may not need additional IOP lowering procedures that allows you to bypass the trabecular meshwork. So in this scenario, if you have visually significant cataract, then you would, of course, consider cataract extraction first. If the angle then reopens and intraocular pressure is well controlled, then of course, everyone is happy. But whereas on the other hand, if there is persistent appositional angle closure after cataract extraction with possibly contribution from a plateau iris configuration, then you may consider argon laser peripheral iridoplasty to deal with the plateau iris. On the other hand, if there's no visually significant cataract, then you may consider laser peripheral iridotomy to eliminate pupillary block. Afterwards, if there is still persistent appositional angle closure with ocular hypertension, then you would have to decide whether plateau iris syndrome or the lens is the main mechanism contributing to angle closure. If it is plateau iris syndrome, then once again, you can consider argon laser peripheral iridoplasty. Whereas on the other hand, if the lens is deemed the main mechanism contributing to angle closure, then you may consider lens extraction. But of course, in a large proportion of cases, both of these may be contributing. Now, in the next slide here, I'm presenting to you the other end of the clinical spectrum. Now we have a hypothetical 360 degrees of complete synechial angle closure with ocular hypertension with or without glaucomatous optic neuropathy. With synechial angle closure, you would expect that any interventions that deepen the anterior chamber and widen the drainage angle may not allow aqueous to access the trabecular meshwork again because of the peripheral anterior synechia. And so you may have to consider additional IOP lowering procedures that either reduce aqueous production or allows aqueous to bypass the drainage angle. Now, in this scenario, if you have visually significant cataract, then of course you may also start with cataract extraction, depending on the starting intraocular pressure and the requirement for drugs, as well as the targeted extent of IOP reduction. You may consider adding another IOP lowering procedures, and options may include corneal synechiolisis, various forms of cyclophotocoagulation, some forms of mix, and perhaps trabeculectomy, and also even glaucoma drainage device implantation. I'll come back to the decision on whether to add another IOP lowering procedure subsequently. Now, in this scenario, if there's no visually significant cataract, then you may have to decide whether the lens is the predominant mechanism leading to angle closure. If it is, then you may consider clear lens extraction with or without combining it with one other IOP lowering procedure. Whereas if it is not, then you may consider performing just one of these IOP lowering surgery. Now, how do we decide whether to combine fecal emulsification with additional IOP lowering procedure? I think first of all, you have to ask how much IOP and or drug reduction is required in that particular eye. And in order to address this question, you would have to take into consideration preoperative intraocular pressure as well as drug requirement. You have to consider the stage of the glaucoma and also the target IOP, and also the patient's age as well as the rate of progression of visual loss. You would also need to consider how much surgical risk the patient and or the surgeon can accept. And to address this, you would have to take into consideration the status of the operated as well as the fellow eye, and also the patient's visual requirement, taking into consideration the patient's work as well as hobbies. And then, of course, the final decision would have to be made after a very thorough discussion of the pros, cons, and risk of the various surgical options with the patient. Now, this is my own usual lens extraction treatment spectrum. In those PACG cases in whom I do not require a large extent of IOP reduction, I may consider doing fecal emulsification alone. If I need more IOP reduction, then I may consider combining fecal emulsification with endoscopic cyclophotocoagulation, or sometimes other forms of cyclophotocoagulation. And if I need even more IOP and or drug reduction, then I would consider combined fecal trabeculectomy. Thank you very much indeed for your time. And if you are interested to learn more about glaucoma or other subspecialty areas in ophthalmology, please do consider coming to Kuala Lumpur in Malaysia to join us for the 38th Asia Pacific Academy of Ophthalmology Congress in February 2023. I do very much look forward to seeing you then. Thank you very much once again.